everyone, this is Dr. Alex Vasquez with video number 3 in our course on human microbiome and dysbiosis in clinical disease. This is video number 3, in which I will focus on what I consider to be the exemplary clinical prototypes of dysbiosis-induced disease. This page reviews the notices and disclosures, including the fact that I've worked as a consultant researcher and lecturer for Biotics Research Corporation. What I emphasized in the introduction to the first video is that my goal here is to provide you a structured understanding for understanding the microbiome and dysbiosis in clinical disease. I also mentioned to you one of my favorite quotes from Nietzsche that really helped inspire me to not simply provide information, but actually to provide and present my information in a way that's structured and therefore more easy to remember and apply clinically. In Will to Power, Nietzsche is quoted as saying, "In order for a particular species to maintain itself and increase its power, its conception of reality must comprehend enough of the calculable and constant for it to base a scheme of behavior on it." So in order for our comprehension of reality to be useful, in my opinion, we have to structure that and make it manageable as a tool, so to speak, of knowledge, which then can be used effectively and efficiently, especially in clinical practice when we're dealing with so many different variables, including family issues, social issues, personality issues, etc. We really need a structured approach to the information so that we can then focus on the nuances of the clinical encounter. So my goal in this presentation, number 3 in the series, is to actually move beyond a structured understanding and move more toward an interconnected understanding of how dysbiosis can present and contribute to these various clinical patterns that we see in our practices. So what I'm going to emphasize in this presentation, especially when we talk about fibromyalgia, is the way that the information is related and interconnected. So, for example, in video number 1, I talked about some of the adverse physiologic effects and consequences of excess exposure to bacterial endotoxin, whereas in this video, I want to show you how that kind of plays out in clinical practice. Again, I think the best example of that is fibromyalgia. In the Genealogy of Morals, Nietzsche wrote, "In fact, this is the only thing appropriate and proper for a philosopher. We have no right to be isolated in any way. We are not permitted to make isolated mistakes or to run into isolated truths." So again, we want to interconnect things. We want to show how they're related and how these different molecules and mechanisms can result in different patterns of inflammation, different patterns of metabolic impairment that again create the patterns that we see in our clinical practices. My definition of dysbiosis has been for many years that dysbiosis is a relationship of host-microorganism interaction that adversely affects the human host. We, of course, need to consider the total microbial load and the role that that plays in the genesis and perpetuation of sustained inflammatory responses. We need to look at dysbiosis beyond the microbes. When we treat dysbiotic-related diseases, our first approach can be, or we could say the first step, is to look at the microbes. So, for example, that's simple mathematics. We can reduce the total quantity, we can increase the diversity, we can use antibiotic drugs to target adversarial, we might say, microbial populations. In addition to subtracting the adversarial bacteria with antibiotics or dietary change, we can also add more of the good bacteria. Of course, that's exemplified by probiotic therapy. We can also promote immune defenses. So, as I said before, the immune system does its job of controlling these microbial populations. And we can also promote tolerance, because I also told you that a lot of times what we're dealing with and what we're seeing in our clinical practice is an excessive inflammatory response to otherwise benign microbes. Again, we want to move beyond simply thinking in terms of dysbiosis. We want to understand that in terms of multifocal polydysbiosis, because people, of course, can have dysbiosis in numerous locations by numerous microorganisms, and then, of course, they can be adversely affected by several molecular mechanisms and physiologic responses, not simply one or the other. So, for example, we can talk about molecular mimicry in isolation, but that is unlikely to occur in isolation in clinical practice. Usually there's at least a secondary inflammatory response induced by those same microbial molecules as well. So, of course, you know that many more details are provided within the printed clinical monograph that hopefully by now everyone has. Let's focus in on these clinical prototypes. We're going to talk about prototypes such as dyscognition induced by microbes. I call that dysbiotic encephalopathy. We're also going to talk about other brain conditions where the brain becomes more sensitive to signals of pain, fatigue, and depression. That's a manifestation to a large extent. We can use a simple model, let's say, of central sensitization. We can also talk about immune complex arthritis, dermatitis, and vasculitis. And fourthly, on this list, we can also use reactive arthritis as a prototypic model that's very well accepted for exemplifying the way that microbes can induce systemic and musculoskeletal inflammation. I've decided to add a fifth category here, and that is we'll talk about another inflammatory disorder induced by microbes, and that is psoriasis. So, of course, we don't want to consider this information in isolation. We want to understand the role that dysbiosis can play in perpetuating and creating these inflammatory disorders, but we want to understand that within a context of some of the other major triggers, such as pro-inflammatory diet and lifestyle, mitochondrial dysfunction and organelle dysfunction, psychoemotional and social stressors, xenobiotic immunotoxicity, immunophenotype imbalances, and hormonal imbalances as well. I call this the functional inflammology protocol, and this lets us keep our focus upstream rather than looking at the downstream consequences of the actual causes. The medical approach, as we learn in medical school and in our hospital training, of course, is to focus on what's happening downstream and try to intercept those inflammatory mediators before they can continue to perpetuate and cause more damage. However, we're never going to win if all we do is try to intercept those inflammatory mediators because, by definition, if we're using drugs to intercept those inflammatory mediators, they've already been released. The game is already in play, and we're going to have to use more and more drugs to intercept these various inflammatory mediators, whereas, again, what we should be doing is focusing our attention upstream. So, as part of the functional inflammology protocol, I also developed the functional inflammology FIND-SEX acronym so that you can remember each of these 7 components very easily. These are food, infection, nutritional immunomodulation, dysmetabolism, sociology, style of living, stress and sleep, endocrine, and xenobiotic load. So with that quick review, we're going to dive right into today's new information, and I'm going to, of course, provide some context for this as we begin to discuss these dysbiotic prototypes. Of course, the first question that gets posed then is what would reasonably qualify a condition to be considered a prototype of dysbiosis-induced disease? And my answer is these would be conditions wherein microbial manipulation alone, most commonly antimicrobial therapy, is curative. And again, we see that in auto-brewery syndrome. We also see that in fibromyalgia. We again see that in bowel-associated arthritis dermatitis syndrome, which is mediated by circulating immune complexes. We also see this in reactive arthritis, and I'll show you how this also applies to psoriasis. The focus of the program, of course, is on the microbiome and dysbiosis. Even though now I'm going to start talking about certain clinical entities, the goal of this presentation isn't to review each and every treatment available for these conditions, rather to review specifically the role that the microbiome and dysbiosis plays in these exemplary conditions. Again, the focus will be on dysbiotic encephalopathy, fibromyalgia, immune complex mediated disease exemplified by bowel-associated arthritis dermatitis syndrome, which presents with arthritis, dermatitis, and vasculitis. I'll talk about reactive arthritis and, again, psoriasis. Some of these conditions are actually rather simple, like dysbiotic encephalopathy. The model I'll show you today will kind of segue into video number 5, where I focus on gut-brain connections. Immune complex arthritis and dermatitis is also very straightforward, as is reactive arthritis. You can certainly read about reactive arthritis in any good medical textbook. But I think where we really need to focus our time and attention is on the paradigm shifts, and especially fibromyalgia, but for many of you also psoriasis. I don't know how many of you are familiar with the microbial model of psoriasis, but in my opinion, that is the dominant model, and I'll review with you the information that substantiates that. So let's dive in right now to dysbiotic encephalopathy. I'm just going to focus on auto-brewery syndrome in this case, and we're going to use this, again, to kind of set the stage for things that we talk about in video number 5, the emphasis, of course, being the fact that microbes, especially within the gut, can produce such a massive quantity of microbial metabolites, and these can cross the intestinal epithelium, these can bypass the liver, and then bypass the blood-brain barrier and affect neurocognitive function. So in that regard, I wanted to draw your attention again to this video that's available called Drunk Without Alcohol, Strange Condition Ferments Carbohydrate in the Gut into Alcohol, which then, of course, adversely affects neurocognitive function. In this presentation, On ABC News in August of 2014, 2 cases were presented of men who had repeated episodes of inebriation secondary to alcohol intoxication, even though they hadn't been drinking alcohol. They had simply been consuming carbohydrates that were then fermented in the gut into alcohol, and I'll show you some excerpts from that video as well.
You're about to see the video for yourself. A wife recording her own husband who seems drunk. Police at one point even arresting him for a DUI. They thought he was drunk too. But the medical mystery was that he'd hardly had a drink. It was something else. Here's Deborah Roberts.
34-year-old Nick Hess is the classic active guy. He bikes, swims, plays volleyball. His wife Karen can barely keep up.
I'm the more serious person. He really keeps things lighthearted. We're almost like complete opposites.
She's the order to the chaos over here, I guess. I'm an upbeat, like, hyperactive, fun guy.
Even with different personalities and career paths, she's in an office, he's now a waiter. Life was good.
Is everybody good so far?
But then there was something else, something really strange.
We would be watching television episode after episode, and by the end of the evening, he would start to be confused and he would start slurring, and he did smell like he had alcohol on his breath.
Karen began recording Nick on her phone.
I don't feel good.
You don't feel good?
Yeah.
What do you feel like?
I feel like I'm on some hard drug or something.
Had he been drinking at that point?
No, we were together all day, watching television. Have you had anything to drink?
Nothing. Not one thing. Why are you recording me?
Because I want to show this to the doctors.
How intoxicated did he appear at times?
It got really bad.
She was filming me. I mooned her on camera. I slurred and was swerving. I used a lot of profanity. When I looked at it, because I wouldn't believe it, my heart just fell like straight down.
Desperate for answers, Nick and Karen took their video to doctor after doctor.
There was one doctor that said, I think you have a closet alcoholic on your hands.
Even Karen began to wonder if the man she's known for 10 years had a deep secret.
I went through the entire house looking for alcohol in the mattresses, everywhere, in between the towels on the towel rack, anywhere that I think that you could find a small bottle or a small flask. So the painful part was just doubting him.
There was no evidence that Nick may have been drinking until one night in 2011, when driving just a few blocks from home, Nick says he was hit by an oncoming car.
I cut through this alley, and right up here is where the accident happened. I picked up my phone and I called the police instantly.
But when they arrived, police quickly make Nick the focus of the investigation.
Nick, how much you paid to drink tonight?
I had 1 beer.
1 beer?
Yeah.
How long ago was that?
About 12 hours ago.
Slurring and wobbly, police are convinced he's had more than 1 beer and insist on a breathalyzer.
Blow, 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 blow. There you go.
Then startling results. 0.236 according to the police report. Nick was nearly 3 times over the legal limit.
You now are under arrest for operating a vehicle under the influence.
What did you think when you got the news that he'd been pulled over for DUI?
It just made me more determined to try and figure out what was going on with him.
Now skittish about driving, Nick began biking, but even that would become problematic. Nick took a bad fall and was rushed to the ER, where he got this news.
So they couldn't give me medication because they said I'd had alcohol in my system. When they told me I was drinking, I told them they were crazy. I'd been with my wife all day, I had nothing to drink.
So what's happening with Nick? It's a bona fide medical mystery. Karen, certain that her husband is no alcoholic, turns to her computer for hours researching.
I finally begged her, please stop. Like, there's nothing that we can do anymore. I may just have to live with this. Please stop.
But luckily for Nick, his wife wouldn't stop.
I had come across this article about auto brewing. It was like, oh my gosh, this is what he has. I'm convinced of it.
An aha moment. Auto brewery, Karen learns, is when excess yeast in the intestine ferments carbohydrates and other sugary food into, get this, alcohol.
We believe this is where the yeast resides.
Dr. Barbara Cordell, one of the authors of the case study, had a patient like Nick who was plagued by inexplicable drunkenness. She put her patient under observation with no access to alcohol.
They fed him a high carbohydrate diet and checked his blood alcohol level every 2 hours. The next day, his blood alcohol level went up on its own.
And when they looked at the yeast in his intestines,
this type of yeast that was in our patient is the same yeast that is used to brew beer.
his stomach was a microbrewery. Now Karen needed to find a local Ohio doctor who would be open to the suggestion. She discovered Harvard-trained Dr. Anoop Kanodia. As for Nick's results, off the charts, 4 times the normal amount.
It picked up the highest level of yeast I've ever seen on a patient. This is what your other doctors are missing.
So he had Nick completely change his diet.
We had him take out all the foods that break down to sugar.
Things like breads, pasta, and rice. And guess what? After just 4 weeks of making simple diet changes, his strange affliction vanished.
No wooziness? No intoxication?
No.
What'd that feel like for you?
It was awesome.
It's incredible. After dealing with for so long, I was in such major denial.
But you had your guy back.
Yeah, it was the Nick I fell in love with.
I'm the luckiest person alive. I keep getting better and better, and I love it. I love it.
So in this example, we're simply using ethanol from endogenous fermentation as an exemplary model for how things can be produced within the gut, bypass the liver, bypass the blood-brain barrier, and then affect neurocognitive function. Many cases of autobrewery syndrome have been published within the peer-reviewed medical research literature. You can see this case study of gut fermentation syndrome autobrewery with Saccharomyces cerevisiae. This patient was treated with antifungal drugs and a low-carbohydrate diet. And so we're also, as I said before, kind of segueing into treatment. You'll find that antimicrobials and carbohydrate restriction and dietary modification are some of the mainstays for treatments that we use when we're addressing gut dysbiosis. I will, of course, review that in much more detail in the following video, video number 4, where I talk specifically about gastrointestinal dysbiosis. Let's look at another case with a little more detail here, autobrewery syndrome in a child with short gut syndrome. This is a 13-year-old girl who had long-standing short bowel syndrome secondary to jejunal atresia and necrotizing enterocolitis that she suffered as an infant. Luckily for her, even though she was experiencing some very severe and negative adverse effects, her father was a physician, diagnosed her with autobrewery syndrome, and treated her appropriately. She had small intestine aspiration, which found Candida glabrata and Saccharomyces cerevisiae. She was treated with antibiotics, which were, of course, of no use because those just kill bacteria, whereas the alcohol is produced by yeast. And then she was treated with antifungal drug fluconazole, and that led to permanent resolution of her recurrent microbial inebriation, we might call it. So in a lot of these case reports, these patients suffer actually quite severe alcohol intoxication. Sometimes their blood alcohol levels are 250, 350, with the legal limit, of course, being 100. So these patients are very, very drunk, again, from alcohol fermented within their own gastrointestinal tract. Let's take that model a step farther, and let's look at this case of hepatic encephalopathy in the absence of liver disease. This is a case from my own clinical practice. This is a 45-year-old male with debilitating fatigue, neuromuscular symptoms, and elevated ammonia, despite the fact that he does not have liver disease. And so I think this gives us a chance to kind of step back from the disease and appreciate the concept that what we're looking at here is an excessive intestinal microbial load, as evidenced by his hydrogen and methane test, as you can see here. He's got severe small intestine bacterial overgrowth. He also has elevated ammonia, consistent with hepatic encephalopathy, but of course, I think most of us appreciate that hepatic encephalopathy is a clinical diagnosis, not simply based on elevated ammonia. But again, I still think that this case represents a model for understanding that, yes, gastrointestinal microbes can kind of come into a position of so much metabolic power, we might say, or so much metabolic production that they actually overwhelm the liver, even if the liver is healthy. In the early medical literature, the term gastrointestinal dysbiosis was only rarely used, and they more commonly used the term autointoxication. In this quite excellent article from the Journal of the American Academy of Dermatology in 1986, these authors reviewed the autointoxication concept and connected it with reactive arthritis, psoriasis, pyoderma gangrenosum, and ankylosing spondylitis. Let's take a quick look through this article and see if we can pull out a few more clinical pearls. They note that the gut contains the most copious antigenic reservoir in the body, that being of microbial antigens and immunogens, and they also specifically mention bowel-associated dermatitis arthritis syndrome and its associated manifestations of fever, chills, muscle pain, Raynaud's phenomenon, polyarthritis, nephritis, erythema nodosum, and other cutaneous manifestations, and the fact that these symptoms respond to gastrointestinal antibiotics. Toward the end of the articles, the authors hypothesize that even minor perturbations of gut mucosal barrier function may be an important event in many dermatologic diseases, arthritic diseases, uveitis, and IgA or immune complex nephropathy. So let's conclude this very brief section on dysbiotic encephalopathy by saying that intestinal microbes are quantitatively massive and can produce metabolites that bypass the gut, liver, blood-brain barrier to influence brain function. For some of you, that might sound pretty obvious, while for others, and really for all of us, it's still pretty shaking because we as humans like to think of the mind as pure, perhaps even divinely originated. So the idea that intestinal bacteria and other microbes can affect mental function is a bit repugnant, in part because it makes us feel vulnerable and fallible and reminds us of our own mortality. Now let's dive into one of my favorite topics, which is fibromyalgia. The reason that fibromyalgia is one of my favorite topics is because it blends three of my other favorite topics, and those are dysbiosis, mitochondrial dysfunction, and in this case, social injustice. So I'm going to show you that dysbiosis is the cause of fibromyalgia. That leads to a secondary mitochondrial dysfunction. And interestingly enough, when we look at the divergence of basic science with clinical practice, we can also touch upon the concept and topic of social injustice, because I think the medical treatment of fibromyalgia perfectly exemplifies the extent to which the medical profession and medical practice can be easily co-opted, or more specifically hijacked, by the commercial interests of the pharmaceutical industry, despite a mountain of research pointing directly to the cause and cure of this condition. I've been publishing on fibromyalgia since 2008, when I first published a clinical monograph called Musculoskeletal Pain, Expanded Clinical Strategies. This was a continuing medical education monograph commissioned by the Institute for Functional Medicine. In 2012, I published a little handbook called Fibromyalgia in a Nutshell and produced a few videos associated with that. I've also continued to review this material in other publications, as well as in postgraduate presentations that I've delivered throughout North America and also in Europe. So, in the focus of this presentation, I would like to clearly establish that dysbiosis accounts completely for all of the major clinical characteristics of fibromyalgia, and that the logical treatment that thereby follows should be the treatment of choice, the standard of care. By so doing, I will by extension establish that the medical analgesic treatment of fibromyalgia is completely misguided. Furthermore, not only is the medical analgesic treatment of fibromyalgia misguided, but by being more expensive, more dangerous, non-curative, and therefore obligatory, meaning that it forces patients to remain dependent on drugs, I think it is therefore unethical. The extent to which the medical profession accepts and uses a treatment protocol that is unnecessarily expensive, dangerous, non-curative, and unethical is proportionate to the extent to which medical practice in this regard is unscientific, misguided, and out of accord with its promulgated goals, which is the welfare of patients. So in order to build the model of fibromyalgia as a dysbiotic disease, I'll review each of the key components listed to the right of this slide, and then I'll start at the bottom of this list with the mechanisms and molecules, and then ascend upward to the clinical implications and proof. Also, necessarily and importantly, I'll spend some time deconstructing the erroneous model that suggests that fibromyalgia is a disorder of primary central sensitization that quote-unquote needs to be medicated with expensive, ineffective, and hazardous drugs. Critical thought and analysis are intellectually vital but socially condemned these days, as critical thought in general and science in particular have become increasingly politicized. In my opinion, true, authentic postgraduate education must not focus solely on incorporating new information. It must also include the critique and excision of erroneous information that has become inaccurately or inappropriately incorporated into the body of knowledge. So as you can see on the right-hand side of this page, I'm going to start with tertiary and supportive criteria showing internal consistency and molecular plausibility. I will then ascend to secondary criteria, evidence of a causative microbial load, which has already been established in these patients. And then we'll conclude with the primary criteria, showing that fibromyalgia is indeed responsive to microbial interventions, especially the use of non-absorbable gastrointestinal antibiotics. Again, we need to spend a little time deconstructing what's already been published so many times because for many of you, especially for those of you who are new to functional medicine, you might not be aware that a lot of the information that's out there, even though it's well accepted, it's not accurate and it should not be well accepted. It should have been, in my opinion, refuted at the level of the editors if they had had the gumption and the interest to actually present, in my opinion, more accurate information. So, as we all learned from science fiction movies, sometimes we have to unlearn what we have learned. And according to Pablo Picasso, every act of creation is at first an act of destruction. So we have to deconstruct the old paradigm and then bring in a new one. I'm sure we're all familiar with this diagram from the 1990 criteria for fibromyalgia. These criteria required the demonstration of at least 11 out of 18 tender points as assessed by a clinician's physical exam. Very unfortunately, even though this was published in the 1990 criteria, in the 2010 criteria, the need for a physical exam was completely excluded. And in fact, the authors stated that they had the intention of excluding the need for a clinician's physical exam. So let's look at those criteria side by side. In 1990, the diagnosis of fibromyalgia required a clinician's judgment and physical exam. In 2010, 20 years later, the diagnosis of fibromyalgia became an easy self-diagnosis that people could do with internet checklists, etc. So the clinician was basically eliminated from the criteria by eliminating the need for a tender point exam. In 1990, the criteria were quite narrow for a very specific diagnosis. In 2010, the criteria became very broad, and the author stated that the problem, quote-unquote problem, was that the previous diagnostic criteria were too limiting and too narrow, too specific. Well, diagnostic criteria for any disease should be narrow and specific. That's what makes a disease a specific disease, not a symptom cluster. So I was suspect when I read that in the original report in 2010, where the author stated that they had the intention specifically to make the criteria more broad. That certainly does not serve patients with this disease because it broadens and makes less meaningful the consideration and our understanding of fibromyalgia. In 1990, patients cured of the disease no longer met criteria, and I think that's very normal and legitimate, whereas in the 2010 criteria, the stated problem that was addressed was that these patients could be cured and they no longer met criteria for the diagnosis. Well, that's not a problem in clinical medicine. When patients are cured, by definition, they should no longer meet criteria for the disease. So the question becomes, for anyone who I think read this article with any amount of diligence, why did the authors specifically dismantle the curability of fibromyalgia, we might say, by making the diagnosis more durable? Who does that serve? It really doesn't serve the patient, in my opinion. So we'll discuss that as we go through. And in 1990, the criteria, in my opinion, were very valid. The goal was to make the diagnosis of fibromyalgia clinically meaningful. In 2010, I think the shift went from validity to profitability. The stated goals by the authors were to make the diagnosis of fibromyalgia easier, broader, and more durable. Again, that does not serve patients. I think it really only serves private and profitable interests. Of very specific note, the 2010 criteria were sponsored, yes indeed, by a drug company. Fibromyalgia is commonly described as a quote-unquote idiopathic syndrome, principally characterized by widespread body pain and numerous myofascial tender points at specific locations, most common in women 20 to 50 years of age, and often presents with other complaints, such as fatigue, migraine headaches, altered sleep patterns, and gastrointestinal disturbance. Again, it's commonly described as being quote-unquote idiopathic, which means we don't know the cause, with strong neuropsychogenic influences. The mainstays of medical treatment are, of course, as you would already guess, perpetual pharmacotherapy and adjunctive use of psychotherapy and limited exercise. What you'll notice very specifically as we go through the pathophysiology of fibromyalgia is that pharmacotherapy, psychotherapy, and limited exercise will absolutely fail to effectively address the legitimate cause of fibromyalgia. Again, these patients commonly have irritable bowel syndrome, migraine headaches, dyscognition, and environmental intolerance, and multiple chemical sensitivity, and I'll show you how all of that overlaps on one of the upcoming pages. We also note that patients with fibromyalgia syndrome, or what I call fibromyalgia disease, frequently have histologic and functional abnormalities in their muscle tissue. They also show consistent mitochondrial defects. They also have secondary coenzyme Q10 deficiency and increased levels of oxidative stress. So, for example, if we just look at these 4 items, which have been proven again and again among patients with fibromyalgia, this alone shows you that fibromyalgia cannot be solely due to so-called primary central sensitization. A brain disorder cannot cause these problems. A brain disorder cannot cause problems in the muscle, as well as the mitochondria, as well as secondary inflammatory and oxidative consequences. So we have to be looking at something that is occurring outside of the enclosure of the central nervous system. So let's integrate these 4 factors into our model of fibromyalgia. Again, histologic and functional abnormalities of muscle tissue, mitochondrial defects, coenzyme Q10 deficiency, and oxidative stress, number 4. Moving on now to number 5, we see neuroendocrine abnormalities, low-grade immune activation, of course, bacterial overgrowth in the small bowel, which is, in my opinion, the cause of fibromyalgia. We also commonly see vitamin D deficiency in these patients and low plasma levels of L-tryptophan. Central sensitization is indeed seen in patients with fibromyalgia, so the most easy way to understand central sensitization is that the brain does become more sensitive to the reception and perception of pain signals. So these patients do feel more pain from stimuli that should otherwise not normally trigger a pain response or a pain perception. So fact number 1, central sensitization is a real neurophysiologic phenomenon whereby the central nervous system develops a low threshold for pain perception, resulting in the sense of pain from stimuli that should not be painful, also called allodynia. The controversy is that many doctors believe or have been led to believe that the pain of fibromyalgia is due to primary central sensitization and that the condition needs to be treated indefinitely with pain-relieving drugs. I think the notion of primary central sensitization as the cause of pain in fibromyalgia is scientifically untenable. I think it's illogical based on the published research. I think it's medically irresponsible because it forces doctors to not treat an otherwise treatable condition. And I also think it's ethically harmful because it fails to maintain the physician's ethical responsibilities to maintain patient autonomy, to provide beneficent care, and to not cause harm. And we'll see that a lot of the drugs that are FDA approved for fibromyalgia are actually quite dangerous in addition to being ineffective. So again, many doctors have been led to believe that the pain of fibromyalgia is due to primary central sensitization and that the condition needs to be treated indefinitely with pain-relieving drugs. Here we see the former president of the American Pain Society. He says, "The problem fundamentally in fibromyalgia is that the ability of the body to sense noxious stimuli has been distorted." And then he gives some vague reasons for this. He says it could be a viral syndrome, it could be trauma, or he says it could come out of the blue without any precipitating event.
Most people think that the problem fundamentally in fibromyalgia is that the ability of the body to sense noxious stimuli has been distorted, so that something that most people feel as being non-painful is perceived by the person with fibromyalgia as being painful. Why that is not known. What causes that to occur in someone who was normal before is not known. We do know that some people develop these chronic widespread pain syndromes after getting a viral syndrome. So it's possible the nervous system can be invaded by the virus or by chemicals produced by the virus, and that causes altered neurological functioning. Sometimes fibromyalgia occurs after trauma. Sometimes fibromyalgia appears to occur out of the blue without any precipitating event. But the bottom line is that people with fibromyalgia are experiencing chronic severe pain, typically, at multiple sites, and now they need to be taken very seriously. They need to be understood as having an organic disease process like any other chronic disease. They need to be assessed in terms of the pain, and they need to be offered a multimodality strategy for pain control, which tries to get the pain down.
So for those of you who have studied at least a little bit of the history of medicine, you will probably recall that early medicine was based on magical thinking and spontaneous generation. And here we see magical thinking and spontaneous generation again return to the practice of medicine with the belief or the presumption or the assertion that fibromyalgia could just happen out of the blue without any precipitating event. Let's take a look at some words of wisdom from the American Academy of Family Physicians. This was published in 2007. Again, they conclude that fibromyalgia is an idiopathic chronic pain syndrome characterized by sleep disturbance, fatigue, headache, morning stiffness, paresthesias, and anxiety. Also, depression is quite common among these patients. This article also emphasizes the need to find 11 out of 18 tender points at specific anatomic sites. Of course, that was later overturned in the 2010 criteria. And not surprisingly, the conclusion of this article is that physicians should use a quote-unquote multidimensional approach with patient education, cognitive behavioral therapy, exercise physical therapy, and of course, analgesic pharmacologic therapy. So in order to reach these types of conclusions, a lot of research has to be overlooked. So let's try to recall, as we look at the other data, that this was published in 2007. So let's look at what was published before 2007 that should have resulted in a different conclusion rather than the fact that these patients, quote-unquote, need behavior therapy, psychotherapy, physical therapy, limited exercise, and endless analgesic drug therapy. Moving on now from American Family Physician, let's take a look at Mayo Clinic Proceedings 2011. A lot of the assumptions that were published in the abstract of this article, for example, are completely wrong, namely that fibromyalgia has a neurogenic origin, that it is a disorder of pain processing, and that these patients need pharmacological therapy as the main treatment intervention. You'll see that this article has 3 authors, and you'll also notice that each of these 3 authors has been paid by 3 separate drug companies for their authorship of this article. Pfizer, Forest Labs, and Eli Lilly are the 3 companies that have FDA approval for the 3 drugs for the treatment of fibromyalgia. I'll review each of those drugs with you in just a moment, but let's look at the first 2. We see that Cymbalta has FDA approval for fibromyalgia, and it's produced by Eli Lilly. We also see that Lyrica or pregabalin is also approved for the treatment of fibromyalgia, and it's produced by Pfizer. Speaking of Pfizer, we also notice that the Fibro Collaborative Group, which also helped produce this review, was also sponsored by Pfizer. The Fibro Collaborative is described here as a quote-unquote diverse group of leading experts, all of them, of course, funded by the drug company that makes